Good morning, everyone. Good morning. Good evening, rather. We're looking forward to tomorrow. Good evening, everyone. I hope you can hear me loud and clear. And welcome to this online webinar today, hosted by Sun Pharma and CPD accredited by the Kenya Obstetrics and Gynecological Society. Today, we have the pleasure of discussing a very interesting topic that is on the molecule letrozole. And that shall be done by none other than our discussant, who is no stranger to us today. I will introduce her later. So the schematic for today shall be, we shall have our talk, after which we will have a brief presentation by Sun Pharma. I will introduce, that is by Nyawera Muriuki, then a Q&A. So today's discussant is no stranger to us all. About 22 years ago, I walked into an OBGYN unit in Mombasa, and lo and behold, I heard a very jovial young lady taking the ward round. That's the same lady who taught me how to do my first cesarean section. And ladies and gentlemen, today our discussant is none other than Dr. Maureen Owiti, who is the head of department OBGYN at Kenyatta National Hospital, also is a consultant in her own right, OBGYN, and fertility specialist. She shall take us through. So over to you, Maureen, and tell us what you have for us this evening. Thank you.
Thank you, Tony. And I think I've corrected to Sun Pharma. I am the former head of department. I think we have a new head of department for the last 1 year, but still in Kenyatta, going strong. And I'd like to thank everyone. Let me just put on my screen for a minute. So hi, everyone. And I'd really just like to say thank you to all who are attending, and especially to COGS and Sun Pharma for giving me this opportunity to discuss a topic that I think we all know, but sometimes ni kufukuza tu, just to clear a few cobwebs. There's nothing really new that has happened in ovulation induction. I think there are more exciting things happening in fertility management, but this is always the first line of treatment. So let me share my screen. So thank you very much for giving me this opportunity. I don't know, are we able to see my screen?
Yes, we are.
Tony? Okay, thank you. Okay, so ovulation induction, optimizing protocols for better outcomes. For purposes of this talk, we're going to concentrate mostly on oral ovulation induction agents. And I always love history. I think I always try to would help us demystify some of these things. In 1958, there was a gentleman named Gemzel, and he's attributed for the first successful induction of ovulation, and he actually had pituitary-derived gonadotrophins. We have another colleague, and that is Greenblatt, who is attributed or has the honor of reported to have a successful induction using clomiphene citrate, and that was in 1961. So I think what everybody always confuses is what exactly ovulation induction is. And we have to remember that you giving letrozole or clomiphene in a woman who is ovulating would not be ovulation induction. Ovulation induction is when you induce ovulation in women with anovulatory cycles. So that is very important for us to remember. And the goal of ovulation induction would be monofollicular growth, release the oocytes, and again, in anovulatory women. This is vis-a-vis superovulation, which is, I think, what most of us do. And this is to encourage multiple eggs or multifollicular ovulation, and to improve chances of conception in those who are already ovulating. So it's just differentiating those two terms, ovulation induction and superovulation. So who are those who undergo an ovulation? And I think we all know this, whereby WHO has the 3 groups of people. This classification was made in 1973 and includes WHO Group 1, which have the hypothalamic pituitary failure. This is normally common in women with people, things like anorexia, those who do extreme exercise. And we have non-monogonic anovulation. And this is our proverbial patients with PCOS and hyperprolactinemia. And we have the WHO type 3, which is ovarian failure. So again, just going through that in WHO type 1, you are going to have low levels of gonadotrophins and estrogen. And the affected organs are always going to be the hypothalamus and pituitary. And in these people, they have hypothalamic amenorrhea. And we have said it's associated with eating disorders, exercise, and stress. And mainstay of treatment for these would be lifestyle. So you probably need multidisciplinary care, a lot of psychotherapy, and gonadotrophin therapy would really help these women as well. Our type 2 majority is the PCOS women. They have normal levels of estrogen and gonadotrophins, and affected organs, normally the ovaries. And this is the largest group. And lifestyle is also still a treatment option. You can do ovulation induction, which is what we're discussing mostly. And you can also do surgical interventions. In type 3, these are people who have high levels of gonadotrophin, so FSH and LH levels are elevated, and very low levels of estrogen, meaning they're having ovarian failure. And in this type of women, you're definitely going to need to give them some hormone replacement therapy, especially if it's premature ovarian failure. And if they desire fertility, probably they would need donors to assist them achieve their reproductive goals. We must remember, though this framework is useful, I always like that medicine does not read books. You don't find people that strictly follow this criteria. However, it's just a baseline for us to understand the topic for the day. We have to remember that it takes about 10 weeks for the primordial follicle to develop into the preanthral stage. And this is what we call the gonadotrophic independent folliculogenesis. These cohort will now start this from influence of FSH produced in the pituitary, are going to start growing. And at around day 6, I think you'll remember the issue of dominance. You're going to have that follicle that has a lot of FSH receptors will become dominant and produce estrogen. And it's from this estrogen, they're going to get a negative feedback mechanism and cause atresia of the less developed follicles. There are ways of confirming ovulation, and I've always loved my teachers, and everything will always start with a good history. So are they menstruating regularly? And around the time of ovulation, are they having cervical mucus changes? So I think we have that proverbial, it's that thin, slimy, pulley mucus. And some women will experience Mittelschmerz, which is the period pain during ovulation due to release of fluid in the abdominal cavity that causes a lot of irritation, or just stretching of the ovary, of the ovarian capsule. You want to be a little bit more scientific, but still basic. We can always do the basal body temperature, and we remember there's always that slight rise. And we can also still check the cervical mucus. And tests, I think I have many clients who are now using urinary ovulation detection kits. We tend to do tracking with ultrasound, and you can also check your progesterone levels. And I think we all remember that on day 21, if you have progesterone above 10 nanograms, that can be deduced that ovulation has taken place. You can also do an endometrial biopsy, and you're going to find you now have a more of a proliferative endometrium. And the surest confirmation of ovulation, however, it'll be a bit late, is the fact that somebody has a pregnancy. So if a pregnancy test is positive, we all know she definitely must have ovulated. Which ovulation induction agents are available? So we have our selective estrogen receptor modulators, and I think the most common is clomiphene citrate. There's tamoxifen, and there are a few others, but these are what are normally used for ovulation induction. We have aromatase inhibitors like letrozole and gonadotropins in the form of follicle-stimulating hormone or hormone menotropin. We all know history of this is that the drug that was very popular was clomiphene citrate. So we'll start with clomiphene citrate. It's still a first line of therapy, but though guidelines are changing or have changed, that letrozole is now considered the first line. So both clomiphene and letrozole can be used as first line for ovulation induction. So how does clomiphene citrate work? And this is going to interfere with the negative feedback loop, whereby clomiphene is going to occupy the estrogen receptors because estrogen is not going to, the FSH receptors are going to be saturated. You're going to find that follicle stimulating hormone is going to be increased, and then you're going to promote growth and maturation of ovarian follicles. So it'll act as an estrogen receptor antagonist in the hypothalamus and pituitary gland, and it's going to compete with estrogen binding in these receptors. By blocking estrogen's negative feedback, they're going to allow increased secretion of GnRH from the hypothalamus, and which in turn is going to increase release of FSH. The FSH is also obviously an LH, obviously going to promote growth and maturation of the follicle, leading to ovulation. We also have the tissue-specific effects, and we know, I think we've discussed on the hypothalamus. On the ovary, it's going to interact with the estrogen receptors, and it's going to promote growth of the ovarian follicles. And on the uterus, I think we all remember, unfortunately, it has a paradoxical effect. For some people, you're going to have the thin endometrium, whereas others, it can actually have proper growth of the endometrium. It also affects other tissues such as bone and breast tissue. However, for ovulation induction, this is not relevant to us today. I remember it was always 5, 5, 50. So it was multiples of 5, whereby the traditional protocol for clomiphene citrate for ovulation induction would be you start on day 5 of the cycle using 50 milligrams of clomiphene citrate and 50 milligrams of clomiphene citrate. Just sorry, there's someone trying to call me. Let me just go on flight mode. Okay, thank you. 50 milligrams of clomiphene citrate and for 5 days. And however, you can always start from day 2 of the cycle to day 5, and starting beyond day 5 will be of no use. I don't know if I can see a number of my residents in the group. If someone can tell us why starting beyond day 6 will be no use, though I think I've already mentioned why. Celeste, I saw you in the group. I don't know if you'd care to fathom why. Okay, maybe I'm putting them in a box. But remember, we said that by day 6, dominance would already have occurred. So, and you'd want to keep other follicles growing. The dosage, you can always adjust the dosage. I think we all do this, that if you did the 50 milligrams didn't work, you go up to 100 next cycle, most of us don't go beyond 150 milligrams of clomiphene citrate, and that normally works. And this is just a diagram of giving clomiphene citrate from day 5, and this is a dose of 100 milligrams per day. So what do you do when your clomiphene citrate fails? So I think, again, this will be a challenge because, as I've said, guidelines have changed and aromatase inhibitors are now considered as first-line therapy. You find that letrozole is going to block conversion of androstenedione to estrone and testosterone to estradiol and prevent systemic biosynthesis of estrogen. So these low levels of estrogen are going to make that the negative feedback mechanism is cut, and you have stimulation of FSH production. So you have at the level of the hypothalamus, you're going to have this blockage of androstenedione. Let me just see if I can get my pointer. Okay, it's somewhere. I hope you can see this. So androstenedione is going to not be converted into estrogen. So the negative feedback effect is not going to be there. And because of that, you're going to have stimulation of FSH, and that's going to stimulate the production of the follicles. I don't know what I've done. My thing is not moving. My cursor is not moving. Okay, I think close. Okay, great. Okay. Okay. So you find also we have tissue-specific effects of the aromatase inhibitors, and they're going to act on the ovaries. Again, we've said it's stopping conversion of androgens to estrogens. And then in the brain, because of the reduced levels of estrogen in the brain, this removes the negative feedback effect. On adipose tissues, I remember there's always the issue of peripheral conversion. And on the endometrium, unlike clomiphene, you find that aromatase inhibitors are going to have an impact on, you're not going to have that negative impact of a thin endometrium. And on bone, I think this is what is used in breast cancer. It has been associated with reduced bone mineral density and increased risk of fractures. Now, if you were to compare clomiphene citrate and letrozole, what we do know is that the mechanism of action, I think we have discussed. The half-life of clomiphene is very long, 5 to 7 days, vis-a-vis letrozole, which is about very short, 45 hours. Anti-estrogenic effects, you find you're going to get a thin endometrium and altered cervical mucus with clomiphene citrate, whereas for letrozole, you're going to have a thick and favorable endometrium with favorable cervical mucus. Your uterine blood flow is decreased with clomiphene, whereas it's increased with letrozole. You actually have a potentially higher rate of miscarriages with clomiphene and a less incidence with letrozole. OHSS risk is higher with clomiphene. I think we must remember that even with ovulation induction, when you can get OHSS. And it's significantly lower in letrozole as compared with clomiphene. Multiple pregnancy, I think letrozole is associated with a higher rate of monofollicular growth as compared to clomiphene. And there's the issue of congenital anomalies. You find, contrary to, again, previous research, I think when letrozole started in the market, there was a lot of bad talk that there was an increased risk of congenital anomalies, but research has actually shown that there's a lower risk of congenital anomalies. So if we move on to letrozole, which protocols can we use? We have the standard protocol whereby you start with about 2.5 milligrams of letrozole, normally between day 2 and 3. And it's just easier for in terms of explaining to the client. But remember, we have said you can start day 2, 3, 4, or 5. And you're going to give a maximum dose of 7.5 milligrams per day. And if you compare, Casper et al. Did a research, and compared to letrozole, you had a higher monofollicular rate of monofollicular growth. The anti-estrogenic effects of the endometrium are not seen. Again, shorter half-life, meaning less complication and lower serum levels of estrogen. So this is just a diagram starting letrozole on day 3. You may give a trigger with HCG just to ensure that ovulation occurs. And again, we normally use ovulation induction prior to intrauterine insemination or timed intercourse. We find that there was a research, again, done by Battiston et al., and they wanted to see letrozole as a first-line drug in women with polycystic ovarian syndrome. And in their group, they had about 135 women using letrozole and 127 using clomiphene citrate. And their conclusion was that letrozole was superior to clomiphene citrate in those who have never used any treatment for PCOS. And I think this, with many other studies, is what has founded that most of us, I think if I ask most of you, what are you using for ovulation induction? I probably think that majority will put up their hands at their first line is going to be letrozole. We have the extended protocol, and you find that there are those women who, if we're just giving them the 5-day dose, they're not going to have the desired effect. So you can actually extend your duration of use of letrozole to about 10 days. And the rationale behind this is that if you continue, you extend the FSH window, and as the FSH window levels fall, the dominant follicle will remain. But if you extend the duration of letrozole, you're going to maintain FSH levels above threshold, allowing multifollicular development. Though, interestingly, what we're saying is that letrozole is associated with monofollicular development, but maybe just maintaining also the dominant follicle. So this is just a diagram of the extended protocol. You use letrozole from day 2 up to day 11, and you can use a dose of 2.5 or 5. Again, the use of HCG is up to you, whether you want to do that or whether you're going to just track with ovulation detection kits if that is going to occur. If you use HCG, you're able to offer them timed intercourse so that you tell them to have intercourse 24 to 26 hours after administration of the HCG. You would have been tracking, and your follicle is, you have best results when your follicle is at least 18 millimeters in size. Then there was the use of letrozole, and again, in clomiphene-resistant women. And so these are people who have used some form of therapy before. And the main outcome was the number of mature follicles, estrogen levels, progesterone, and endometrial thickness. That was what was being measured. And you find that in the group that was using letrozole, for all the parameters, this was much better. And you find that you had that. Then you can also do short versus long letrozole protocols. So remember, we have talked about the extended vis-a-vis the normal standard protocol, and you can see from this that if you are using the short protocol, you're going to have about 4 follicles vis-a-vis 6 in the long protocol. Those reaching above 18 millimeters, that's also for 40 millimeters, were about 2 vis-a-vis 3. Endometrial thickness pre-treatment was 4.8 to 4.5. However, it was similar on day of HCG administration, which was 10 millimeters. We always aim to have an endometrial thickness above 7 millimeters or 8 millimeters. So 10 millimeters is actually very optimal. And you can see the serum estrogen level is very ideal. This is telling us you have about 2 follicles, because if we all remember, a mature follicle releases about 150 picograms of estradiol. And so when you see a figure of 300, that's telling you have at least 2 follicles which are mature. We had said that the serum progesterone levels on day 21, that if it's above 10, it's indicative of ovulation. And you can see in letrozole, it's 10, vis-a-vis in the short letrozole 9. And pregnancy rates was slightly higher in the extended group, and miscarriage rates was I think similar in the two groups. So you find that extended protocol, if we're to look at it, had a higher pregnancy and could be used in clomiphene resistant, and if a standard protocol for letrozole is also not working, and also as a first line treatment. We also have another trial, and in this trial we had women with polycystic ovarian disease undergoing IUI, and they received letrozole, and this was comparing the 2 doses of whether they're going to use 2.5 versus 5 milligrams. And we know that with the 5 milligram dose, the pregnancy rates were higher as compared to the 2.5. And again, if I was to do a poll, what dose of letrozole do most of us start on? It'll be 5 milligrams vis-a-vis the 2.5 milligrams. We also have what is called a step-up protocol, whereby on every day, you're going to start on day 2. So on day 2, you're going to start with 2.5 milligrams. Day 3, you double the dose, to 5 milligrams. So every day you add 2.5 milligrams on top. So you'll have 2.5, 5, 7.5, and the last you're going to have 10. And in this step-up protocol, you're going to have a superovulation, and you found that you're going to have more follicles produced in the step-up protocol. And if the people compared it with clomiphene, so we had 2.2 follicles vis-a-vis 1.5 with clomiphene citrate, and the endometrial thickness on day of HCG was similar, and the clinical pregnancy rate was much, much higher, almost 3 times in the step-up protocol vis-a-vis clomiphene citrate. So this new protocol is useful, and in terms of resistance. And again, I think we talked about 2.5. Now, if you find clomiphene citrate, sorry, this should have come a bit earlier, is resistant, you can also use HMG or FSH to extend your protocol. So this is another way of, if you're using clomiphene citrate as your first line of treatment, you can use FSH or HMG, which are gonadotrophins, to increase pregnancy or monofollicular development. So you're going to start with your clomiphene citrate traditionally on day 2. You're going to use it for 5 days, and then you're going to give FSH, normally a low dose. You can use 75 international units, or half that, that is 37.5 international units. You give an injection for 3 days, and around day 12, day 14, you can give an injection, or you can do an ultrasound, check your estrogen levels. And if you find that you have your follicle is greater than 14 millimeters, estrogen above 200 picograms, you can give your HCG 5,000 or 10,000 international units, and you are able to do IUI within 35 hours of administration of your HCG, or you can do the timed intercourse as well. You have there was a study which was trying to do the effect of letrozole, compare in those who used letrozole alone and letrozole with gonadotrophins. And we found that you had 3 groups in this particular study. So the first group, they were just using 2.5 milligrams of letrozole for 5 days. The second group, they were using 5 milligrams of letrozole for 5 days. And the last group, they were using recombinant, and in both studies, they were using with recombinant FSH, and the last group was using recombinant FSH alone. And the primary outcomes for all the studies, you found that those, if you look at, there was no statistical difference between all the groups, except I think in the letrozole if you're using the 5 milligrams, it just had a shorter number of days of use of the recombinant FSH. And if you look at the cost of recombinant FSH, it's very expensive. So this would be an advantage to use letrozole 5 milligrams. You'd have a lower dose of recombinant FSH being used. But in terms of the outcomes, remember we want monofollicular growth. When you use letrozole, you had only about 1.3 to 1.4 follicles vis-a-vis 2. Endometrial thickness was almost the same in all the group. And obviously, because you are using a lower dose of recombinant FSH, the cost of treatment, you can see doing $600. That would be about 70K for one cycle of using recombinant FSH. For the point of ovulation induction, this would make it a very expensive cycle. Whereas if you're using letrozole in combination with recombinant FSH, you find the cost of your cycle is going to go much, much lower. There are other ways you can use letrozole, and you can use letrozole, what is called a single dose protocol. On day 3, you just give 20 milligrams of letrozole. And then from there, you can also use a regimen whereby you're going to start recombinant FSH or HMG from day 7 until the day of HCG administration. And you found that if you are to compare the 2 cycles of the standard dose of letrozole with recombinant FSH and the single dose, the pregnancy rates were comparable, and you had lower levels definitely of serum estradiol on day of HCG administration. You can also use a higher dose of letrozole, up to 7.5, and you have what is called the stair-step protocol. And this, you are going to do ultrasound. You're going to, so in this, somebody did a study to compare those 2 methods, and they were using clomiphene citrate 50 milligrams from day 2 to day 6, or 2.5 milligrams of letrozole from day 2 to day 6. And then after that, you did ultrasound examination and on the last dose of the drug and gave HCG. In case there was no follicle reaction, or if the single follicle was less than 18, you're going to double the dose of letrozole on day 6 and without withdrawal bleeding. And you're going to continue doing the examinations for the next 7 days. And you keep just increasing the dose of the letrozole until a maximum, or clomiphene and that was the clomiphene and letrozole, until a maximum of 150 for clomiphene citrate and 7.5. And you find for letrozole, again, you did a similar thing whereby you're just increasing the dose of letrozole and clomiphene, but in this stair-step protocol, again, you have higher ovulation rates with letrozole, higher pregnancy rates, and a shorter time to menstruation. We have what is called minimum dose stimulation protocols, and you're going to use a very low dose of gonadotropin. And again, this is obviously going to be associated with pregnancy rates and improved live birth rates. And then you can have what is called a letrozole timing protocol. And this is given on the 5th day of the menstrual cycle when you start it. So I think it's similar to what we used to do with clomiphene citrate. And again, this was associated with higher cumulative conception rates and medium endometrial thickness levels. In terms of the conventional protocol, if you're comparing letrozole and clomiphene, I think we've already done this previously. And again, higher pregnancy rates, obviously the letrozole. So we have in 2023, there's new guidelines for management of polycystic ovarian syndrome. And you find that letrozole is the preferred first-line pharmacological infertility therapy. And you can also do clomiphene in combination with metformin as a first-line therapy. Then gonadotrophins or ovarian surgery will be used as second-line therapy. And IVF will be used as your third-line therapy. And given the underlying risk of pregnancy complications in PCOS, for I think IVF, a single embryo transfer should be preferred in those patients. So these were just some of the what the guidelines were saying, and in terms of the evidence. This is just a flow chart of the same. So your first line is going to be letrozole or clomiphene citrate with metformin. Your second line is going to be gonadotrophins or surgery. And the last one is going to be IVF. So in summary, you're going to have better pregnancy outcomes and higher live birth rates with letrozole as compared to clomiphene citrate in polycystic ovarian patients. You're going to have it's effective in clomiphene citrate resistant patients who, if you give your first line as clomiphene citrate, it's going to reduce the dose of gonadotrophins used, required, and it's superior if you're to compare using clomiphene citrate with gonadotrophins and letrozole using gonadotrophins. A letrozole cycle is superior to a clomiphene citrate cycle. It has better monofollicular development and resulting in lower multiple pregnancies. I think as Africans, we always wonder why people don't want to have multiple pregnancies. But again, it's understanding the cost of treatment is very, very high with multiple pregnancies. You have more complications in terms of things like gestational diabetes and preeclampsia with multiple pregnancies. And the cost of inpatient management is very, very high in the Western world. The antiestrogenic effects are less, and again, lower cycle cancellation and a lower risk of hyperstimulation. And a lot of safety has been established in clinical studies. Again, we had talked that you can use gonadotrophins, and gonadotrophins you can use low dose regimens, which can be daily. And you can start with doses as low as 37.5 international units per day. And if you're very wide, you can also use them on alternate days. And there's whether or not you can add an antagonist to prevent ovulation prior to the date of ovulation. There's also the issue of, can you use adjuvants? So if you find, and especially if you're using clomiphene, you can use dexamethasone or metformin. And the same, you can also use, I think we're all using insulin sensitizers. So we have drugs like myanacetyl and the decaroinositol. You can use N-acetylcysteine, climadinon. This is a herbal drug that is very helpful, though I've not seen it in our market currently. There are a lot of agents that have L-carnitine and all sorts of multivitamin supplements that people are using as adjuvants. There's also the issue of cupping therapy, and remembering that because our primary target for anovulation are our PCOS patients, always remember the lifestyle. So we're going to encourage them weight loss and exercise. We had said that I think our third line should be the IVF. Asked, I would revise guidelines because the current guidelines do recommend that you should actually do assisted reproduction therapy and before you do laparoscopic ovarian drilling. And with that, I'll say thank you for your kind attention.
Well, thank you very much, Maureen, for that very detailed presentation. My goodness, that takes us back into med school and better. Thank you very much. You were obviously a teacher. Nashukuru sana. For those of us who are listening, remember, the Q&A is going to come at the tail end. We want to give an opportunity now to Sun Pharma, represented by Nyawira Muriuki, to give us a brief presentation. Remember, Sun Pharma are the ones who bring to us such wonderful drugs as Susten, Ranferon, Susten being their micronized progesterone, Ranferon, of course, our hematinic, known and beloved to many of us, and their brand of Letrozole, which is Letroz. So over to you, Nyawira. You can unmute and take us through your presentation. Asante sana.
Thank you so much, Dr. Wassuna. Also appreciating Dr. Maureen Owiti for that particular presentation on ovulation induction. So please just let me know if my slide does not move so that I can just change the mode. My name is Nyawira. I'm glad to give a brief overview on the products and of offering that we have in the gynecology therapy. So, but just as a glance to start as who we are at Sun Pharma. Sun Pharma is the fourth largest global generic branded generic company of the globe. We are ranked #1 in India, and in Kenya we've been around since the year 1993. So we've been around for more than 30 years, providing quality medications in different therapeutic segments. When you think about gynecology, cardiology, and what have you, we are in almost all therapeutic segments in this particular market. So we're committed to gynecology with our products, delivering these products for more than 30 years. As Dr. Wassuna has actually said, we are not new with our range of products because we bring to you legacy brands in your specialty, brands like Susten, brands like Letroz, brands like Ranferon, we have Cabalin, we have Lupride. And we also love to see that our portfolio is actually from contraception to conception with confidence kind of portfolio, because when you look at it, we do have oral contraceptive offering, we do have now the natural micronized progesterone, our brand of Susten. Then a lot has been spoken about today with regard to Letrozole, the aromatase inhibitor of choice for an ovulation induction, and also our legacy brand, Ranferon. But today, in the interest of not just dwelling on the brands that we have actually had a long legacy with you, we have recently come into the segment with a few other additions in the gyne-nutri segment, the gyne-nutra segment. So as Dr. Maureen was actually ending her presentation, she talked about the advance, and I think the range that I'm about to present about, 3 particular products, would come in handy even as we discuss about fertility. So from the strength of iron that we're used to, from the strength of iron to the nourishment of multivitamins, we want to continue the legacy of Ranferon. And what we've done is we've brought an additional SKU in the range of Ranferon, because we do know that motherhood demands more than just iron. and it calls for complete nourishment for her and the baby, which is why we have entered this segment with a product we are calling Ranferon Mom. This is particularly just an extension of Ranferon. It is a multivitamin. We believe that will empower motherhood and also nourish the dreams of motherhood. So this journey continues with an even more powerful mission to support motherhood. And Ranferon Mom is multivitamin that will deliver optimal nutrition support to your patients. It consists of essential vitamins, minerals, and as well as omega-3. So this slide is actually a deep dive of the different multivitamins that it has, from DHA to EPA, folic acid. It also has a component of iron and also other important macro and micronutrients. So the indication of this is a dietary supplement, a source of polyunsaturated fatty acids that has the omega-3 family, the DHA and EPA. For pregnancy planning, can also be used mostly in pregnancy as well as lactation. And this is only, you give 1 capsule daily. This product is also coming as chocolate flavored. It has a chocolate flavor just to try and mask that particular taste of the omega-3, because we do understand that in the when you talk about pregnancy and people who are already having morning sickness, that would be an issue. But we've tried as much as we can to try and mask that. So this product is now available in the market. So it will deliver optimal nutrition support from conception to cuddles, whether you're talking about pregnancy planning, during pregnancy, in the first, second, and third trimester, as well as during breastfeeding. This can be used across these 3. Again, because there's also increasing evidence of the omega-3 fatty acids and their effect on the fetus and pregnancy, whether you're talking about neurodevelopment, you're talking about the pregnancy outcomes, cognitive development of the fetus associated. I think by now there's a lot of increasing evidence on the numerous benefits that can be associated with omega-3 fatty acid consumption, both in pregnancy and also postpartum. And this is regardless of whether it's consumed in the diet with seafood or via supplements such as fish oil. So this again explains the rationale of why this product has the DHA EPA. Moving on to also another product in the Gyne Nutra segment, we have introduced our calcium in the market. This is Reviton Nustrong Mom. It's a powerful combination of dicalcium malate, vitamin D2, folic acid, and glycine, which would promote healthy and strong bones through every stage of a woman's life. Mostly, I do know that we prescribe calcium in pregnancy. Some also continue all the way to lactation, and obviously in postmenopause, we see a lot of issues of calcium. So this is also an appropriate segment where this particular product can actually be prescribed. So the one thing about our calcium is that dicalcium malate is a very, very unique calcium salt that would help to maintain bone mass. And the reason we are combining it with vitamin D2, which is the vegan source of vitamin D2, is because this would help to increase the calcium absorption from the intestine. And obviously folic acid, which would help very much for the pregnant moms. And why include glycine, which is available in 10 mg? This supports the muscle growth as well as repair. So Revital Nustrong Mom is also available in the market now. We just got it to the market about 2 months ago. And as I was saying, the calcium malate is actually more bioavailable than calcium carbonate, and is the most superior salt available right now in the market in as far as calcium is concerned. Then the last product we have added, when you talk about infertility, we do know that there are also a couple of fertility factors that would be associated with men. So Revital Newman is also a range that we have introduced a couple of months ago, 2 months to be precise. It contains a blend of specific ingredients for better results that would actually improve several sperm parameters. When you talk about the coenzyme Q10, is something you'd probably be looking forward because you want to improve the sperm motility. And obviously, when you're talking about fertility, you have to discuss about the catenine. So this particular product has L-catenine as well as acetyl L-catenine. So all these products are actually available in the market currently. And the Revital Newman is actually available as a sachet formulation. So you just put 1 sachet in a drink, you mix the contents of the sachet in a glass of water or juice, and you can drink. The products are actually available at very, very affordable rates. So we're looking forward to your support in terms of these products alongside the legacy products that I had highlighted there before. So I'd just like to return this session back to Dr. Wassuna. Thank you so much, and also appreciate COGS for the partnership we have had today. Thank you so much. Back to you, Doc.
Thank you, Nyawera. You're a natural at speaking. Thank you very much for giving us a run by on some of the excellent products that you do have. And now we allow to listen to questions coming in from the people who are tuned in and logged in. And so we have quite a few, just about 5. I shall begin with the first question. Of course, this goes to Dr. Owiti, or of course to some of our seniors who are here who can obviously give input. Thank you very much. If you'd like to, you raise your hand and to give added input. Thank you. So the first one goes this way. Beyond how many cycles of clomiphene citrate use, are we talking about an association with CA ovary? The question is about the association of CA ovary with clomiphene citrate use, especially with respect to how many cycles. Over to you, Maureen. Can you hear me, Maureen? She's muted, so let me unmute her.
Sorry, Wassuna.
All right, there you go. Did you hear the question, though?
Yes, I heard it was regarding clomiphene citrate and
Okay.
what do you call it, CA ovary. There's that potential. It has been postulated that if you use clomiphene citrate for more than 6 cycles, there's a potential for risk of ovarian cancer. So we do recommend that you shouldn't use clomiphene citrate for more than 6 cycles.
Thank you very much for that. The second question goes thusly. For those with anovulatory cycles, how do you use progesterone and which formulations are preferable? What is the role of progesterone in anovulatory cycles and how would you administer it best?
Okay, so I think you must remember that when you're doing the ovulation induction, you're trying to mimic the natural cycle. So if ovulation has occurred, you should have adequate levels of progesterone. I think one of the slides I did mention was that from between day 21 and 28 of cycle, if you have levels above 10 nanograms, or I think it's 300 picograms, then you can confirm that you have ovulation and you actually have adequate levels of progesterone. So if you have adequate levels of progesterone, there may actually be no need, because remember we're doing monofollicular development. That's the goal. So there may be no need to do progesterone supplementation. Having had said that, if you do have lower levels of progesterone, there could be a role of supplementing progesterone. Progesterone, I think, is one of those molecules that we as obstetricians love. I'm a huge fan of progesterone. I think we use it in mothers with a recurrent pregnancy loss. We use it when we're doing controlled ovarian hyperstimulation. So the doses are there, and you can use. It will now depend on the formulation that you're using. We know the various formulations. We have from oral, we have vaginal, and I think that's the micronized progesterone. And we also have injectable progesterone. So it just depends on the formulation you're using. And injectable comes both as intramuscular, and you now have an aqueous form, which is subcutaneous, which would be more user-friendly. So really, that would be a whole topic. Probably if guys are interested, we can have use of progesterone in the future, because that will be a now whole nother lecture. Yeah.
Thank you very much. Okay, concerning the new kid on the block, myo-inositol, what's the recommended dose if you're combining it with letrozole when we're trying to achieve optimal ovulation induction, that is, in fertility management?
Okay. For me, my ancestor is not a new kid, but yeah, it's one of those that does really help. Recommended dose always would be your myoinositol should be at least a gram, and it's a gram BD. So that works out to about 2 grams per day. That's the preferred dose that I prefer, and it's actually what is recommended. So yeah, there are schools of thought that you should have that 40-to-1 ratio with D-chiroinositol. There are some reps who tell you there's no need because it's converted and stuff like that. So that one is up to you. But for the myoinositol, you have to have at least 2 grams per day in divided doses. So that is 1 gram twice a day.
Thank you very much. All right, timed intercourse. Expound on it when you're using the letrozole long protocol.
Okay, so again, for the timed intercourse, remember, this is also specifically when you're giving the HCG injection, because you are able to, if you give HCG, you would want them to have intercourse at least 26 hours after the administration of HCG.
Okay, thank you very much for that. All right, one listener noted that you particularly mentioned the use of clomiphene in combination with metformin in patients with PCOS. Could you also apply that for letrozole, or does the combination only apply to clomiphene? In other words, clomiphene in combination with the metformin. Can you also use letrozole with metformin?
Definitely, you can use letrozole with metformin, but I think a lot of studies have been done to see when you have clomiphene resistance and you're not getting ovulation induction clomiphene resistance, and the use of metformin together with it. So probably that's why there's a lot of that, but it is possible to use metformin in combination with letrozole.
And the second part of that particular person's question, doctor's question, is as follows, that they've also come across the practice of combining letrozole and clomiphene. Any supported evidence to support this?
I think I'd recommend that person to probably do
using both letrozole and clomiphene.
Yes, thank you. I'd recommend that person to probably just come up with a study and show what the evidence shows, because I think we have combined clomiphene with gonadotrophins. We have combined letrozole with gonadotrophins. Why shouldn't we combine clomiphene and letrozole? Because they have a slightly different mechanism of action. I haven't come across it, so probably if they can just forward that paper, we can also just look at it. But that would be an interesting, and I think for my postgraduate students, that could be a very interesting topic. Maybe not for the postgrad research because of numbers, but an interesting topic all the same for those who are pursuing fertility.
There's a question here on timing, the fact that we do have short and long regimens, and that all has a bearing with timing, day 2 to 7, day 3 to 7, etc., day 3, 20 milligrams. What about those with irregular cycles? How then will you administer letrozole?
Okay, so regardless whether the cycle is regular or not regular, your start point is the period. Okay, so it's when they have the period, you start menstruation on this date. So you're either going to start your letrozole on day 2 or day 3, day 4, day 5. What we have said is that you should not start treatment beyond day 6, because you may have that the dominant follicle has already started to form. So what do you call this thing? So it really doesn't matter which day you start. We know you have an advantage the later you start, because you're extending the FSH window so that you have higher levels of FSH for a prolonged period of time. For convenience to explain to patients, because explain to a patient that you wait for your periods 5 days, then start, they all tend to get confused, so that sometimes you don't confuse. It's much easier to tell a patient that if your period start today, start the next day. That'll be day 2 of the cycle. Because what I've found is that some patients, I don't know if you've experienced this, that you give the patient instructions, start on day 5. They wait for the period to end and now cut 5 days later and then start the letrozole. And you're like, oh my goodness, there's nothing that they would have achieved by doing this. So sometimes it's just for convenience, for ease, to drop confusion. But studies have shown that when you start around day 5, you're extending the FSH window longer, you're actually going to have a better results with that.
Lovely. A bit of a comment on ovarian hyperstimulation syndrome. People in Mashinani say they have to deal with OHSS in its severest form, and they stick to the lowest safe dosage of the molecules. Any comparison between OHSS in clomiphene citrate vis-a-vis letrozole?
I think one of my slides showed that it's significantly lower with letrozole as compared with clomiphene, and it's just simply because clomiphene has a higher rate of monofollicular development as compared to, so letrozole has a lower rate of monofollicular development as compared to clomiphene.
All right, so comorbidities, especially cardiovascular events, stroke. Can we safely use letrozole in patients who have had cerebrovascular events as a history?
Probably, I think it should be safe, but you'd really have to just go in conjunction with your cardiologist or whoever is the physician that's managing to also give you a green light. So I think just like surgery, you would not want to do, I think we are having a lot of patients, I don't know what's happening, all of a sudden that patients are coming with clots, this central venous sinus thrombosis, that you can't even say that word, that disease, and they are pregnant or they want to have fertility treatment. And you look at health definition being not just the physical, but there's the social, there's the reproductive health and rights. Would you entirely want to deny someone? Fortunately, you find your estrogen levels are not going to be that elevated. So I feel it would be safe to use in those patients.
All right, so we have one question, quite interesting here. After 1 year's usage of Depo, medroxyprogesterone acetate, Depo-Provera, and of course the patient is amenorrheic, no periods at all, is it advisable to use letrozole?
Are you using letrozole to induce the periods? I would like to be clear what the question is, because definitely if she's amenorrheic, I think like everybody, you're going to have to do a standard investigation, because sometimes she's amenorrheic, has she conceived? So you're just going to go through your normal, you do your beta HCG, and if it's negative, probably try to induce a period. You can try a progesterone challenge. I know they've been on the Depo, and see when you withdraw if they bleed. If they don't, again, maybe add estrogen and start. And then from there is when I'd say maybe once you've been able to induce a period, you can start the letrozole.
Another question, is there any synergistic effect if you use any drugs, supplements, for example, pregnant care conception together with letrozole? Any problem with using them at all?
I think like everybody, the things like pregnant care conception, they all have these antioxidants, they have vitamins. And I tell people, look, there are vitamins which are supposed to make you healthier. So we don't have any challenge. And personally, I do use quite a lot of these products, and especially those that contain a little bit of minoxidil, contain the L-carnitine, the coenzyme Q10, all those antioxidants, they have been shown to be helpful. Of course, the increased cost of care, you have to look at the profile of your patients. And I normally give patients the option. Minimum, we all know, for those intending to conceive, the minimum multivitamin you need to give them is folic acid at your 400 micrograms per day, minimum dose. But if they can afford, I would not be against using them, and it can only help.
All right. One of us is asking for a slight recap on when to start clomiphene timing and also when to have intercourse. I assume they are asking when to have intercourse for conception, because if you just leave it as when to have intercourse, that is a whole different ball game there.
Okay, so again, I think it's a similar question to the timed intercourse. We have agreed whether it's clomiphene or letrozole, you can start on day 2, day 3, day 4, day 5. You don't start beyond day 5. Any of those days you can start the clomiphene or letrozole. In terms, if you want timed intercourse, you're going to monitor on ultrasound the size of your follicle. You have a follicle greater than 18 millimeters, greater than or equal to 18 millimeters. You can now give an injection of HCG. With the injection of HCG, you advise the couple to have intercourse about 24, 26 hours after the injection. That's when you're going to be able to give them the timed intercourse. If you're not giving HCG, you cannot determine exactly what time the ovulation is going to take part. So what we normally do is just request the couple to have alternate intercourse on alternate days.
I remember the question was asked before whether you can use both clomiphene and letrozole. A question maybe that piggybacks on that is mode of action of the two. Are they different? Are they the same? Clomiphene vis-a-vis letrozole.
Okay, in terms of negative feedback, they ish work the same, but it's remembering that for the selective estrogen modulators, which is receptor modulators, they block the estrogen receptors and therefore increasing the what do you call it, release of FSH. Whereas aromatase inhibitors, they are actually now going to stop conversion of androgens into estrogen, and therefore, again, having low estrogen levels, so again, resulting in FSH. So their mode of action is different. So mechanism of action is different. So it could be, I think it would be an interesting research to see if you combine the two, are you getting better results or not?
Thank you for that. I think there's a question which you already answered about letrozole vis-a-vis ovarian cancer, to which we said we use 6, I believe, cycles.
Yes.
Is that correct?
Yeah.
Yes, and a lot of people are commenting and saying this is an excellent and great presentation. Thank you very, very much. Maybe to wrap it up, I would want to ask that you just give a very recap, your last thoughts. This is from your heart concerning this matter. Remember, we used to say, the books say this, but consultant professor, what do you say? So what says thou concerning the above?
Okay, thank you, Tony, for always putting me in a box, but I think
It's an
I'll
open box. You can jump out if you wish.
So my open box. So mine is I think all the agents for ovulation induction have been proven, they work, but from the research done, you can see that letrozole has a big advantage over clomiphene citrate. So for me on ovulation induction, and the guidelines have changed that letrozole should be our first line of treatment. So when we're doing ovulation induction, use letrozole. Thank you.
Thank you very much, everyone, for tuning in. I know there are lots of questions coming in, but in the interests of time, I believe maybe some of these can be labeled and directed at Dr. Owiti. I want to just give a vote of thanks. Thank you so much to Sun Pharma for this platform and for obviously being very faithful with giving us these excellent medications with which we can help to better the lives of our patients. I also want to thank the COGS for for partnering with us and ensuring that we get CPD accredited for this particular online presentation. But I also want to say thank you so much for you. We are actually 241 people who have tuned in. That's a great number. Thank you very much to every one of you. We want to say thank you, Asante Sana. Have a lovely, lovely week and weekend coming ahead, and look forward to the next presentation that will come courtesy of Sun Pharma. Asanteni Sana, you are now okay to leave and go and eat at your own leisure and pleasure. Asanteni Sana.